Screen recording with microphone. Microphone is on. Okay, auscultation. Okay, what is cardiac cycle? Mainly cardiac cycle is of two phases. One is systole and diastole. Which is the shortest one abdina, it is systole, which is 0.3 seconds. Diastole lasts for 0.5 seconds. So if someone asks which is the organ which is taking rest for most of the time in the body, it is heart only, because more than 50% of the time it is relaxing. Now systole 0.3 seconds, there are 3 phases of systole. Diastole there are 5 phases basically. So importantly what you have to remember, when I mean systole, it is always ventricular systole. I am not talking about the atrium. Atrial systole is just 0.1 seconds. It correlates with the last part of diastole. So the last part of ventricular diastole is by atrial systole. Yeah, atrial systole. So what are the phases of systolic contraction? Systole. First one is, the most important thing is isovolumetric contraction. The next one is rapid ejection phase. Next thing is slow ejection phase. So basically what happens is, at the end of diastole, the ventricular cavity gets filled with blood. The ventricle starts contracting. When it contracts, what happens? The AV valve is already open. It gets closed initially. Okay, so mitral valve and tricuspid valve gets closed. So the two outlets are closed. Now the ventricle gets contracted. This is called as isovolumetric contraction. So when the pressure increases to a certain extent, what happens? The aortic valve and the tricuspid valve. Aortic valve and pulmonary valve opens. So this marks the phase of rapid ejection phase. So after the pressure gets reduced, the ejection will be slow. It is called a slow ejection phase. So in systole, the most important event is isovolumetric contraction, rapid ejection after the opening of aortic valve, and the pulmonary valve, rapid ejection, slow ejection. So when the pressure in the ventricle drops after the slow ejection phase, the ventricle starts relaxing. At the onset of relaxation, what happens? The opened aortic valve and pulmonary valve will close. So like opening of the mitral and tricuspid valve marks the beginning of systole. The opening, closure of the aortic and pulmonary valve marks the beginning of diastole. Alright. So what are the phases of diastole? Some say small stage called as protodiastole. The most important phase is isovolumetric relaxation. Isovolumetric relaxation. When the pressure in the ventricle falls further, the next event which happens is opening of the mitral valve and tricuspid valve, so that the already filled blood in the ventricle comes down. This is called as rapid filling phase. Again, slow filling phase. Yes, the last phase, the last 0.1 second of the diastole is contributed by atrial contraction, or the second rapid filling phase, atrial contraction.
What the name for this phase is? Atrial systole or?
Atrial systole contributes the last 0.1 seconds of the ventricular diastole. It is called a second rapid filling phase. Okay, so the important phases in the entire cardiac cycle will be, first is isovolumetric contraction, where this contributes to the closure of the mitral valve and tricuspid valve at the beginning of systole. Then comes the rapid ejection and the slow ejection phase. When the pressure drops, the first event in diastole to occur is the closure of the aortic and pulmonary valve. This causes S2, or the second cardiac sound. Then opening of the tricuspid valve and the mitral valve occurs, which causes the rapid filling phase. The mitral and tricuspid valve opens for the second time, that is during the atrial contraction. Okay, so mitral and tricuspid valve opens for 2 times. Remember that. அதான் நீங்கள் எக்கோவில் பார்க்கும்போது உங்களுக்கு மைட்ரல் எம் மாதிரி தானே மூவ் ஆகும். It opens twice. That is because of initial opening is due to the rapid filling phase. Second opening is due to the atrial contraction. Okay. So why to know cardiac cycle is, if you know this cardiac cycle, you can know about the sounds. So what is S1 basically? S1 is a sound which is produced due to the closure of the mitral and tricuspid valve. It marks the beginning of systole, or it marks the beginning of isovolumetric contraction. Right. So it begins the systole. So S1 is contributed by two events, right? Closure of the mitral valve and closure of the tricuspid valve. So theoretically speaking, it has two components, M1 and T1. What is S2 now? It is a sound which is produced due to the closure of the aortic and pulmonary valve at the beginning of the diastole. Again, this again has two components. One is the sound produced due to closure of the aortic valve, which is A2, and sound produced due to the closure of pulmonary valve, which is P2. What important event occurs between S1 and S2? In S1, mitral valve closes. In between S1 and S2, the aortic and pulmonary valve open. So the opening of aortic and pulmonary valve is an important event which occurs between S1 and S2, or it's an important event which occurs during the mid-systole, right? Okay. Now S2, I told you there are two components. What are the other important events which occurs between S2 and the next S1?
Opening up.
I told the mitral valve and tricuspid valve open twice. So first time when it opens, it is due to the rapid filling phase of diastole. So if there is a sound produced due to the rapid filling phase of the ventricle, that sound is called as S3. So in the early rapid filling phase of diastole, the mitral valve opens, tricuspid valve opens, the blood from the atria goes by rapid filling towards the ventricle. If it produces a sound, it is called as S3. What is the second diastolic filling phase? The second rapid filling phase, or the phase of atrial contraction, contributes to the second phase of mitral and tricuspid valve opening. If this produces a sound, it is called as S4.
Okay.
So sequence, S1 is due to closure of the mitral and tricuspid valve.
Yeah.
Click is due to opening of the aortic and pulmonary valve. S2 is due to closure of the aortic and pulmonary valve. S3 is due to the rapid filling phase. S4 is due to the atrial contraction.
Which contributes to second rapid filling.
Yes.
So opening of mitral valve and
Yes,
the
that I didn't mention. Opening occurs before the rapid filling phase, right? So
Yeah.
if any sound due to opening of the mitral valve or tricuspid valve has to occur, it is called as opening snap. It should occur before S3. So the actual sequence of events will be like this. S1, ejection click due to the aortic and pulmonary valve opening. Next comes S2, which is A2 and P2. P2 occurs later than A2. Then comes the opening snap, then S3, S4. So S1, ejection, S2, opening snap, S3, S4, then S1. This is the actual sequence of events. So why I told this basic hemodynamics is, whenever you are auscultating a sound, if you are remembering the hemodynamics, it will be easy to correlate. Okay. Basics of auscultation. Whenever you are describing something, this is the normal order you follow. First, you should know what are the areas of auscultation. Mitral area is the area of apex. Tricuspid area is the left lower sternal border. If they ask how much lower, it is the left fifth intercostal space close to the sternum. That's LLSB, left lower sternal border. Next is the pulmonary area. Mitral, tricuspid. Pulmonary area is the left second intercostal space close to the sternum. Aortic is the right second intercostal space close to the sternum. These are the four primary areas of auscultation. Apart from that, we have few other areas. One is called as the neo-aortic area, also called as the Erb's area, which is the left third intercostal space. Left third intercostal space. And that is the area below the pulmonary area, but it is called as neo-aortic area. I'll tell you the reason why. Another area of importance is Gibson's area. Gibson's area, knowing it is very easy because it is left first intercostal space or left infraclavicular region. This area is important because we hear a particular murmur there. I'll tell that again later. Apart from that, we can hear some extra cardiac sites also. For example, radiation of the aortic stenosis murmur will be heard at the carotid. So we can auscultate the carotid. Radiation of the MR murmur can be heard at the axilla. So axilla, back, all these areas you can auscultate. So main important areas are carotid, axilla, back including the intercostal spaces. So I'll tell them in the relevant places where they are important. So when I mean by area, it doesn't mean the location of the valve. The valve is located elsewhere. But why we are auscultating in these areas is the flow occurs towards these regions. So when I auscultate the mitral area, the blood flow from the mitral left atrium through the mitral valve will go to the apex. Apex is the left ventricle. So that is the direction of the jet. So any vibration or any sound we hear, we'll be hearing it in this area. So it is not the position of the valve, it is the position where the jet hits or the vibration is heard. So tricuspid area also the same thing. One important thing is, if you know the anatomy, remember that this is the sternum. Always aorta originates from the left ventricle, from the left side. It goes towards the right side of the sternum, then it takes a turn, goes posteriorly and comes behind, like that. Aorta starts from the left ventricle. It starts from the left side of the heart at the level of second intercostal space. So this is the left second intercostal space. It starts in this area, goes to the right side, turns posteriorly and comes down. So how will be the direction? If this is the left ventricle, the direction of jet is like this. So the aortic valve is actually situated in the left third intercostal space. That is the area of neo-aortic area. So neo-aortic area is the area of the aortic valve, which is the left third intercostal space. It is the position of the valve. But the direction of aorta is directed towards the right. So when the flow occurs, the jet will hit the right second intercostal space, which is the actual aortic area. So if someone asks you what is the content of the aortic area, it is actually the aortic root. What is the content of the neo-aortic area? It is the aortic valve. Now you know very well, pulmonary artery is anterior to the aorta and it comes like this, it crosses like this, right? So the content of the pulmonary area, or the left second intercostal space, is actually the main pulmonary artery. Right, it comes like this. So the content of the left third intercostal space is the aortic valve. The content of the right second intercostal space or the aortic area is the aortic root. The content of the left second intercostal space or the pulmonary area is the main pulmonary artery. So again, whatever turbulence you hear, it is not due to the valve, it is due to the jet which is hitting the aortic root or the pulmonary root in case of the particular stenotic lesions. Okay, so I told you about neo-aortic area, I told you about the other areas. Gibson's area I'll tell later. This radiation also will tell later. Okay, so this is about the basic thing of area. Why this is also important is some murmurs originating from the left ventricle. Any murmur which is produced due to turbulence within the left ventricle will be better heard in the apex, because apex actually contains left ventricular cavity. But any murmur which is heard in the aortic area or pulmonary area, it is a murmur which crosses the left ventricular cavity. Okay, so if you are hearing a murmur in the tricuspid area, in the pulmonary area or in the aortic area, it means there is a turbulence at the level of the valve or at the level of the outlet. It doesn't mean a pathology which is occurring within the cavity. Example, what is S3? It is a sound which is produced due to the rapid filling of left ventricle during rapid filling phase of diastole. It is a main event of the ventricular cavity. It's not a problem with the outflow. So where it will be best heard? It will be best heard in the apex. What is S4? Again, it is a sound which is produced due to the second rapid filling phase of diastole due to the atrial contraction, where blood comes from the atria into the ventricle. Again, it's a problem with the left ventricular cavity. So S4 will be better heard in the apex or in the mitral area. It has nothing to do with the outflow tract. So you will understand this when you are discussing the further areas. Okay, so the general sequence what you have to do when you are describing auscultation is first to describe the area. For example, you have to go in this order: mitral, tricuspid, pulmonary, aortic. This is the simplest way of saying, but actually you have to auscultate the mitral area, you have to auscultate the tricuspid area, then go every intercostal space towards the pulmonary area. Because tricuspid area blood flow towards the pulmonary artery, right? So you can know the actual hemodynamics when you are going. So over space this method is called as inching method. Never auscultate only the area, inching method. Auscultate from one area to the other, traversing through every intercostal space, so that you can understand each and every change of the intensity of the particular heart sound, so that you can understand the events and hemodynamics better. Similarly, when you are auscultating the aortic area, it will be better to go from the apex towards the aortic area, so that left ventricular to aortic pumping can be better.
Apex to aortic.
Apex to, that is mitral area to the aortic area. This is also inching method. Okay, so this is the order you go. Then after this, you have to auscultate for the neo-aortic area. Any other areas? Then some special situations are there which we will discuss. Okay, so in all these areas, what are the things you have to do is, first thing, say whether S1, S2 is heard or not. First point. Second point, I told you S1 is mainly concerned with mitral and tricuspid valve. So when describing about mitral and tricuspid area, you have to tell about the intensity or the character of S1. Okay, so S1, S2 you have to tell whether it is heard or not. Then in mitral and tricuspid area, always comment about S1. Comment means I will tell you what are things you have to see, mainly about intensity of S1. Third thing is whether any added sounds are there. I told you some added sounds. I told you one of the systolic added sound is ejection click. Diastolic added sound is S3, S4 opening snap. Others I will tell later. So any added sounds are heard or not. Then the fourth point you have to tell is whether any murmur is there.
Added sounds means click.
Clicks, S3, S4 opening snap, tumor plop, prosthetic valve sounds, etc. Okay, this is about M1 mitral and tricuspid area. In pulmonary area, the sequence is similar. Say whether S1, S2 is heard or not. But in pulmonary and aortic area, you have to mention about another important pulmonary area. Another important thing which is called as split. So we will discuss about split also later. Split is nothing but, even though there are two components of mitral valve, we will not hear M1 and T1 separately, but in pulmonary and aortic area, we will be able to hear the two components separately, A2 and P2. So that concept is called a split. If the split is wide, it is abnormal. If the split is narrow, it is abnormal. If the split is reversed, it is abnormal. We will discuss that later. So mention about split. After the split, you have to mention about, in pulmonary area, I can mention about P2 intensity. In aortic area, I can mention about A2 intensity. Then the fourth one will be any added sounds. Fifth one will be murmur. So this is the main sequence. Neo-aortic area, we are mainly looking for only one murmur, which is the early diastolic murmur of aortic regurgitation. Again, we will discuss that sometime later. So in special areas, just what is our thing of concern, that alone it is enough to mention. So every area, whether S1, S2 is heard or not, comment in mitral and tricuspid area about S1, comment in pulmonary and aortic area about split as well as P2 or A2. And what is additional sound? We have finished till murmur. All these are sounds which are arising within the heart. There is one sound which is arising outside that, which is pericardial. So if there is any pericardial, we can add it as the sixth point in all areas. So this is the general sequence. So once this silent auscultation is done, we have to do something called as dynamic auscultation. Dynamic auscultation is we are doing some activities or maneuvers which is increasing or decreasing flow across a particular valve so that we can assess what is happening. So I'll just mention what you are going to see. One, we can do some postural changes. We can ask the patient to sit. We can ask the patient to squat. We can ask the patient to lie down. We can ask the patient to be in left lateral decubitus position. All these are positional changes. Inspiration or expiration is the simplest dynamic auscultation. We know very well that inspiration increases venous return or it increases blood flow to the right side of the heart. So any right-sided event will increase in inspiration. Any right-sided heart sound or any right-sided murmur will increase during inspiration, except only one sound, which is pulmonary ejection click. I'll tell you what the reason for that later. So this is again a dynamic auscultation. The third one will be the famous one, Valsalva maneuver. Fourth one will be isometric hand grip. The fifth one, dynamic auscultation, will be use of some drugs called as amyl nitrate. Okay, and the next dynamic auscultation is drugs. What drug is amyl nitrate? Remember, only one drug. According to Perloff, these drugs are not used now, but just for theoretical purpose, we can know. Okay, so this is the sequence of what you have to do. Okay, shall we go to the next one? We'll start with individual sounds now. Okay, first we'll start with S1. So how is S1 produced? Closure of the mitral and tricuspid valve at the beginning of isovolumetric contraction. It marks the beginning of systole. But the actual definition, we colloquially say that S1 and S2 S1 is produced due to closure of mitral and tricuspid valve. But actually it is not the closure of the valve which is causing the sound, it is the tensing of the valve fibers during sudden closure. So the actual definition, what's the reason for production of S1 is tensing of the valve fibers of mitral and tricuspid valve due to closure at the beginning of isovolumetric contraction. Mitral and tricuspid valve closure. Okay. Next important thing is, it is due to the closure of mitral and tricuspid valve. So by theory, we have two components, M1 and T1. M1 is the sound which is specifically produced due to closure of the mitral valve. T1 is the sound which is produced specifically due to the closure of the tricuspid valve. But actually, this difference is very, very less because the time interval is only 20 milliseconds. So we may not hear this very well. Sometimes it may be heard. Okay, I'm not going in much, but sometimes it may be heard. If at all it is heard, the first component will be M1 because left side is the high pressure chamber, it closes earlier. So M1 occurs first, T1 occurs later. So if M1 is split, the first sound will be split, the first sound will be louder, the second sound will be softer. First sound is M1, second sound is T1. Just remember this one. While finally concluding, we'll just have some rapid discussions. In that, we'll be discussing what's the importance of knowing this S1 split. Now, whenever you are discussing about some sounds, you should know what are the determinants of the particular sound. Particularly, we should know the determinants of S1. What are the determinants of S1? Mainly three important components. One, the distance the mitral valve has to travel prior to closure. This is the one important thing. So what example is, remember just think that this is the left atrium, this is the left ventricle, this is the mitral valve. In mitral stenosis, what happens? The actual valve area is less. So the blood from the left atrium continuously goes through the valve to the left ventricle. So the valve will be open all of the time. So if you always remember, when a door which is completely open closes suddenly, it produces more sound than another door which is partially open, it won't produce that much sound when it closes. So any valve, any condition in which the valve is very lower in position or it is very deep into the left ventricle, when it closes suddenly during the isovolumetric contraction, it produces a louder sound. The typical example is MS. Mitral stenosis. In mitral stenosis, the mitral valve is short. So the blood from the left atrium to the left ventricle will be continuously flowing throughout the diastole. So it keeps the mitral valve continuously open. Continuously open, and it will be fully open. So when the contraction occurs, the mitral valve has to travel a longer distance. Because suppose, assume in a normal valve, the valve will close in between. But in mitral stenosis, the valve will not close. So a fully open valve, when it closes suddenly, it will produce a loud sound. Right? So that is the reason why MS we are hearing a louder sound. So one important determinant is the distance through which the mitral valve has to travel prior to closure. Second mechanism is PR interval or the heart rate. Third one is LV contractility. I won't discuss the actual details what is happening, just remember. If the LV is contracting very well, it will produce a loud sound. So when will LV contract? As per Frank Starling's law, when the left ventricle is distended by more amount of blood, it will contract. Don't think about conditions like mitral regurgitation or tricuspid regurgitation where there's problem with the valve itself. So don't think about those conditions. Think of the physiological volume overload states like anemia, pregnancy, young adults, where when the blood flow is more frequent, two things occur. One, just remember one thing. Now, the left ventricle will be filled with blood. Their contractility is very good. So when the left ventricle contracts with much force, the valve will close very forcefully. So you will hear a loud sound. So good LV contractility as occurs in anemia, pregnancy, young adults, children, high output cardiac states solluvaanga beriberi. So whenever someone says high output states, it should be anemia, pregnancy, young adults, beriberi, PDA. Don't think of MR and TR. MR and TR are hyperdynamic states, but there's a problem with the valve itself. So the mechanism will be different. So these hyperdynamic states, due to increased LV contractility, S1 will be low. Now what about PR interval is, any tachycardia, obviously the heart will contract forcefully. So during a tachycardia, or tachycardia will cause a short PR interval. So increased heart rate or reduced PR, both are going to cause a loud S1. I'm not telling the deeper mechanisms, just to remember the basics. Then the fourth, actually 3 are only given in Harrison, but I have split it into 2 and told. The fourth important main component is the pliability of the valve. Any valve, be it S1, S2, S3 or S4, will produce a sound only when the valve is normal. If the valve is fibrosed, calcified or thrombosed, we will not hear a sound. One important example is mitral valve prosthesis. If the prosthesis is normally functioning, we will hear a prosthetic click, which is a diastolic sound or a systolic sound, added sound. If the prosthetic valve is thrombosed, we will not hear the sound. We have seen one case in a female organ. So the another important determinant is pliable valve. So a mitral stenosis will produce a loud S1 only on the background if the valve is not calcified, not fibrotic. Right? Remember this concept. So the 4 important determinants of S1 are the distance through which the mitral valve has to travel before its closure. So MS is one condition which causes loud S1. Next is the PR interval or heart rate. So any condition causing tachycardia, exercise, pregnancy, everything will cause a loud S1. Any condition where the LV contractility is more, like all physiological hyperdynamic states like anemia, pregnancy, young adults, beriberi, etc. will cause loud S1, provided the valve is pliable. Normal. Pliable means normal, not calcified, not fibrosed valve. So these are the determinants. Now the question comes, I told you loud and soft. I'll finish soft S1. So what are the conditions causing soft S1 now? The straight opposite of these. Bradycardia, right? Long PR interval or bradycardia, both are the same. So tachycardia, short PR causes loud S1. Bradycardia, long PR causes soft S1. Any valvular lesion except MS will cause soft S1. Most of the valvular lesions except the typical example being MR. Because the mitral valve is not going to close. It's an incompetent valve. The valve do not coact. So obviously no sound is going to come. So MR is one typical example for soft S1.
Valvular disease except MS.
Yes. Typically they say like that any valvular heart disease except MS will produce a soft S1 or a normal S1. Now LV contractility. The contractility is good, so S1 will be loud. So heart failure, LV systolic failure will cause a soft S1 obviously. And the fourth thing is non-pliable valve. Calcified, fibrosed,
systolic
failure, heart failure. Calcified or fibrotic valve. So these are the conditions causing soft S1. Now my question is, we are telling loud S1, soft S1, we are understanding hemodynamics and telling it. How will you quantify that this is loud S1? Normally I told you we have to comment about S1's intensity. Sorry, before that one basic I left it in here itself. When describing any heart sound or murmur, there are few words you have to tell. Whenever you are describing sounds, first thing you have to tell about the pitch of the sound. Okay, pitch is nothing but the frequency. Frequency in colloquial term is the shrillness of the sound. A sharp stinging sound will be high frequency. A flat sound will be low frequency. So pitch is the frequency of the sound. It indicates the shrillness or sharpness of the sound. This is pitch. Next is the intensity. Intensity is the loudness of the sound. This is physics. But how can you apply it in clinical practice? So one point, very important point you know is all high pitched sounds are better heard with the diaphragm of the stethoscope, right? So all high pitched sounds are better heard with the diaphragm of the stethoscope. So you are auscultating a patient. What Perloff says is initially start with the bell of the stethoscope. So you are starting with mitral area, then going to the tricuspid area, any area, first auscultate with the bell so that we can pick up low frequency sounds. Low frequency is low pitched sounds. So the sound which is not audible in the bell, then change to the diaphragm and try to hear with that. If you are hearing with the diaphragm, it is high pitched.
Hear high pitched sounds, no?
Bell is for low pitched sounds. High pitched sound is for diaphragm. So any sound which is better heard with the diaphragm of the stethoscope is high pitched sound. Any sound which is heard better with the bell of the stethoscope is a low pitched sound. So when you are speaking to many people, many of you will confuse. This murmur is loud, so it is a high pitched sound. It is not so. Loudness has no correlation with the pitch. Pitch is the sharpness of the sound. How to clinically assess any sound which is better heard with the diaphragm of the stethoscope is high pitched. Any sound which is better heard with the bell of the stethoscope is low pitched. So alternate between bell and stethoscope. That is how you have to mention about pitch. It has nothing to do with our audibleness or loudness, etc.
Yeah.
Another important thing is when you are auscultating with the diaphragm, always keep the diaphragm tight to the chest. Adan diaphragm. But bell should be placed lightly, just to form a skin seal. You should never place the bell tightly. If you place the bell tightly, what will happen? It will become diaphragm. If you place the diaphragm lightly, what will happen? It will become a bell. So leave off the old stethoscopes, the newer Littmann M3 cardio stethoscopes and all, we have something called as tunable diaphragm. If you keep the steth lightly, it will act as a bell. If you keep it tightly, it will act as a diaphragm. It is called as tunable diaphragm. So sometimes they may ask you a question. If you are left with only the diaphragm, don't change the stethoscope. Don't twist the stethoscope. With the particular diaphragm, how will you use it as a bell? Keep it lightly, it will act as a bell. Keep it tightly, it will act as a diaphragm. If you are hearing the sound better on tight pressure, it is high pitched. If you are hearing better on a light pressure, it is low pitched. That's all about pitch. It is nothing to do with the loudness. Intensity is the other name is loudness. Okay, loudness always we have a problem because I may say one sound is loud, another person may say it is normal. So one controversy there is it comes with experience. Some say this is loud sound on first auscultation itself. But in my discussion, I will try to say most of the objective things. For example, I told you S1 is a sound which is heard in the mitral area and tricuspid area. That is in the apex or in the left lower sternal body. If that sound is louder than S2 in the aortic area and pulmonary area, you mean S1 is loud, right? I'll tell again. In the mitral area and tricuspid area, S1 should be louder than S2. That is what I told first itself. Similarly, in the aortic area and the pulmonary area, that is in the base of the heart, S2 should be louder than S1. That is the basic because we are coming close, right? Aortic area, we are close to the aorta. Pulmonary area, we are close to the pulmonary area. But in aortic area, if the S1 sound is louder than S2, it means S1 is louder, right? Similarly, in the apex, if S2 is louder than S1, it means S2 is louder. That's all.
Loud P2 we are saying?
Loud P2 means if, I'll tell again, I'll tell now also. P2 is a sound which is heard only in the pulmonary area. I'll tell that while discussing split. If P2 is heard in any area other than the pulmonary area, it is loud. Right? So P2 is a sound which is heard only in the pulmonary area. If it is heard in any area other than the pulmonary area, it is loud. Simple. So this is the concept of objective loudness or intensity. Nothing to do with experience, but things come with experience. Another thing is I forgot to mention about timing of the sounds and timing of murmur. So when you are discussing sounds, you have to discuss about pitch and intensity. When discussing murmur, you have to tell about pitch, intensity and the timing of the murmur. So I told you S1 is there. S1 marks the beginning of systole. S2 marks the beginning of diastole. So the phase between S1 and S2 is systole. Am I right? The phase between S2 and the next S1 is diastole. What are the two important sound? Okay, we will come again later. Okay, so how to time S1? It is very, very easy. Palpate the carotid. The sound which comes along with carotid is S1. Because ejection starts at that time. So S1 is the sound which comes along with the pulse. S2 has no marker as such. But can S3 be localized? It can be localized. Because what is S3? It is the rapid filling phase of diastole. You know very well that in JVP, rapid filling phase contributes to the Y descent. So in JVP, if you are able to see the Y descent, that is the timing of S3. Okay, if you are able to see S4 is the atrial contraction, so it should cause A wave. So the sound which comes along with A wave in JVP will be the S4. Okay, so S1 is very, very easy. The sound which comes along with pulse is S1. Most of the time we will not be hearing S3 and S4, so obviously the second one which comes is diastole. Now sometimes they may ask you, even without auscultating, can you differentiate between S1 and S2? It is possible. I told you what's the difference between S1 and S2. Systole duration is 0.3 seconds. But the distance between S2 and the S1 will be 0.5 seconds, duration of diastole. So two sounds will be coming together. Two sounds come together, then a gap, then two sounds come together. So even with this auscultatory technique, you can find which one is S1, which is S2. The problem comes when the third sound comes. Because the third sound can be S3, S4, opening snap, tumor plop, ejection click. Ejection click won't be a problem because it comes between S1 and S2. The problem is the third diastolic sound. The third sound is diastolic, it is very, very problematic. So we will discuss later how to differentiate them.
Okay.
So why I told this is how to time. So only time systole, any murmur or a sound which comes after S1, before S2 will be systolic.
Yes.
Right? Finding S2 is very difficult because we cannot time it because there's no event to describe S2. So any sound or any murmur which comes just before S1 will be diastolic. You may ask you, will it be different because after S2 will be before S1, so will there be any difference? There will be a difference because the time difference is different, right? 0.3, 0.5, so you may time it. So a sound which comes just after S1 will,
Just before S1.
sound which comes after S1 will be systolic sound. A sound which comes before S1 will be diastolic sound. It is very easy. Or a sound which comes before pulse will be diastolic sound. A sound which comes after S1 will be a systolic sound. I forgot to mention this initially. So why I started this is, S1, how will you say the loudness now? S1 is normally heard best in the mitral and tricuspid area. If it is louder than the
mitral
S2,
and tricuspid area, other areas if it is loud, when compared to S2, then we can
it is
say
called as loud S1. So cause of loud S1, tachycardia, short PR interval, increased LV contractility, MS. Suppose in atrial fibrillation we tell variable S1, right? We have two things. We have short cycles, long cycles. Short cycle will produce tachycardia. Right? Short cycle will have a loud S1. Long cycle will have a soft S1. Just one added point from Perloff. Okay. When will you say S1 is soft now? Loud S1 you told. It is better heard in the aortic area, it is loud. When will you say it is soft? Simple. The mitral and tricuspid area, S1 is less than second sound. Normally S1 will be louder in mitral and tricuspid area than S2. But in the mitral and tricuspid area, if S1 is softer than S2, it means S1 is softer. It may mean other ways also. It may mean A2 is louder also.
Okay.
But anyway, it's just experience. Based on the other clinical finding, you have to comment there. If S1 is not heard, it is definitely soft. So we say S1 is soft when it is not heard. Give one condition where S1 is not heard. Pansystolic murmur of mitral regurgitation, where the murmur begins with S1. So the actual description of the murmur will be a pansystolic murmur which obliterates S1. So we will not hear S1 at all. So that
murmur of
mitral regurgitation. VST, TR, MR, whatever it may be. We actually describe the murmur as the sound, the murmur engulfs the sound. So if S1 is not heard, obviously it is soft. Or in other words, if you are comparing with a normal A2, we can tell that S1 is soft. So even though telling soft S1 may be difficult, but telling loud S1 is very, very objective only. It doesn't come with experience. So that's all about S1. S1 is over. Coming to S2. Okay, the other things I have written, so there's no need of your pen now. Okay, tell me what's the mechanism of S2. It is not due to mechanism of S2.
S2 not due to closure of
it is not due to closure of the aortic and pulmonary valve. It is due to tensing of the valve fibers during aortic and pulmonary valve closure. During isovolumetric relaxation phase, it marks the beginning of diastole. Right? Actually, what word is given in Perloff is due to tensing of aortic and pulmonary valve cusp during aortical pulmonary vascular recoil. Just one additional point, S2 occurs at the end of T wave. Because you know very well, TP segment is the diastole, right? In ECG. So vascular recoil. S2 occurs at the end of T wave. TP segment is the diastole in ECG. So S2 marks the beginning of diastole. So if you are not able to clinically localize, you can do an ECG and say if the T wave begins, it is S2. Okay, I won't tell about incision. Okay, now the most important component is split. I told you there are two components of S2. One is A2, which is due to the closure of the aortic valve, and P2, which is due to closure of the pulmonary valve. S2 has two components. One is A2, which is due to closure of the aortic valve. Now tensing sollala, I am just telling as such. A2 is due to closure of the aortic valve, P2 is due to closure of the pulmonary valve. But these two sounds are heard separately. Why? Because left-sided is a high pressure system. So the left ventricle contracts against so much of pressure and it comes back normally. So the recoil will be fast in left side of the heart. So A2 occurs earlier. Whereas right-sided circulation is a low capacitance, low pressure system. So the ejection will be for a longer time. So the valve will be open for a longer time. So since it is open for a longer time, it will close late. This is a simple definition. The left side pressure being high, the aortic valve opens fast, it empties fast and closes fast. Whereas the right side being a low capacitance, low pressure system, the ejection goes for a longer time, hence the closure occurs later. Okay, so the word mentioned in the book will be the pulmonary vasculature being a low flow system and pulmonary resistance is only 1/3 of systemic vascular resistance. The elastic recoil of pulmonary artery is less than that of aorta. What I told only it's given here. Pulmonary recoil is lower than that of aorta. That is the only word here you have to remember.
Pulmonary vasculature.
Recoil.
Recoils later than that of the aortic. Elastic recoil of pulmonary artery is less than that of
Pulmonary
aorta.
vasculature.
Being a low flow system and pulmonary resistance is only 1/3 of systemic vascular resistance. The elastic recoil of pulmonary artery is lower than that of aorta. I'll share the notes later. So just write the points which you understand. I'll share this later. Okay, so now I told you A2 comes first, P2 occurs later. Where is the split normally heard? I told you since pulmonary circulation is a low pressure system, the P2 is heard only in the pulmonary area.
Okay.
So splitting is also heard only in the pulmonary area. So how will you assess splitting is? The patient can be in the supine position or 30-degree head and elevation. Suppose you have any doubt, ask the patient to sit with legs dangling. I'll tell the reason sometime later. While discussing dynamic auscultation, I'll tell you. But just remember, first you examine in the supine position or 30-degree elevation. If you have any doubt regarding splitting, examine with legs dangling down, sitting and legs dangling down. Ask the patient to take a deep inspiration. What happens in inspiration? The blood coming to the right side of the heart increases. So again the pulmonary ejection time will be more. So it will take a longer time for the pulmonary valve to close. So
Increased
P2
venous return.
increased venous return to the right side of the heart occurs during inspiration. So P2 widens. Right? So P2 widens. Similarly, during inspiration what happens? More of the blood is retained within the lung. It does not go into the left side of the heart. So A2 closes earlier. So P2 goes later, A2 comes earlier. So if you have to explain diagrammatically means normally A2 P2 is like this. During inspiration what happens? P2 gets delayed because inspiration more amount of blood to the right side, P2 closes later. A2 occurs earlier. This is normally occurring mechanism in any young adult. So during inspiration the split widens. During expiration what happens? The opposite occurs. P2 comes closer, A2 comes closer. So the split narrows. So in normal individuals, you will be able to hear the split, but the split will be wide in inspiration, it will be smaller in expiration, but you will be able to hear in both. We will be hearing it only in the pulmonary area. Okay. Now, this is normal splitting. There is abnormal splitting means, this is important, abnormal splitting is only three things. Either the split may be very wide, the split may be very narrow, the split may reverse, or
Notes is there.
you can have a single S2. I'll just read out the causes later, but just now I'll explain the mechanisms, okay? So what is wide split S2? The simple mechanism is, there is a splitting in
Just a wide split.
wide split. A2 P2 is there. During inspiration it is wide. During expiration also it is heard, but less than that of inspiration. What I told you normally we hear split in both inspiration and expiration, but in inspiration it will be wide, expiration it will be narrow. If the split is wide during both inspiration and expiration, it is called as wide split. So what are the conditions which can cause wide split now?
Now we can appreciate if normally inspiration only we will be able to hear better.
But in expiration also if you are able to hear better, it is wide split.
Wide split.
But the difference will be there. In inspiration it will be even wider. That is split. We have another condition called as persistent wide split. Or fixed wide split. Fixed wide split is A2 P2 will be the same distance. During both inspiration as well as expiration, the distance is the same. That is called as persistent wide split or a fixed wide split. So I told you two mechanisms. One is wide split, that is split is heard both during inspiration as well as expiration, but inspiration is slightly longer than expiration is wide split. Fixed wide split is inspiration and expiration both we are hearing the split, but it is equal. That is called fixed wide split. I'll tell the conditions later. Now what is paradoxical split?
Reverse
P2
split.
comes first, A2 comes later. How will you identify that? Normally in inspiration, split should widen. But in inspiration, if the split narrows, it is reverse split. Simple. So only these are the three abnormalities you have to say when there is a split. Another problem can occur with S2. I told you two components are there, right? One component may be absent or both components may be absent. So since you have understood the basics now, I'll tell the conditions and how it occurs. First I'll tell the split. Wide varying split. That is the first one which I told. That is split is heard better in both inspiration and expiration with the respiratory variation. So what are the conditions which can cause a wide split? P2 should go front or A2 should come earlier.
P2 should go back.
P2 should widen, A2 should shorten. That's all only. No? So what are the conditions which can cause prolonged P2? The right ventricle is not contracting. So right bundle branch block is one condition. So RBBB, P2 goes wider. Simple. So why I am telling this is you can diagnose without ECG bundle branch blocks if you are very eager. Okay, another thing is don't think about this AST, MR. Mitral regurgitation, what happens? Ventricle contracts, it pushes blood into the aorta, it also pushes blood into the mitral valve, back into the aorta, left atrium. So it will contract very easily. Because rather than a single opening, we are having two openings. So contraction will occur early. So AT will come earlier. So MR. So right bundle branch block. Right ventricle is not contracting due to conduction abnormality. It is RBBB. It is not contracting due to RV dysfunction. It is called RV failure. Remember this point very importantly. I will repeat it again. RV failure, always think of massive pulmonary embolism. Valvular PS. Again PS we have a delayed. Right? So three important conditions are RBBB, RV failure, pulmonary embolism, valvular PS, which delays P2. Only one condition which causes early occurrence of A2, which is MR.
Yeah.
So one valvular heart disease we can associate by split. Okay. Idu purinjada. Next one, okay, I won't deal with these things because you will get confused. You understood the basics like pressure and now next one I told you is fixed wide split. Okay, fixed wide split occurs in three conditions. I forgot one condition. Only remember two: ostium secundum ASD and TAPVC. Why these two? Ostium secundum ASD.
Because will be no.
There's a connection between right atrium and left atrium. So there is no difference in pressure. If the blood is coming to the right atrium and the pressure falls in the left side, blood will go from the right atrium to the left atrium. Opposite occurs during expiration. So the pressure equalizes between the right atrium and left atrium. Hence the blood flow to both the ventricles will be the same.
I have a doubt.
Yes.
No pressure or there is no difference in blood receiving both the chambers because inspiration the venous return will increase. That is causing split. Because of AST and TAP.
In inspiration, blood flow to the right atrium will increase.
Because of AST,
it goes into the left ventricle.
So
yes,
that's the difference.
That is the difference. So the actual wordings given in the book are phasic changes in systemic venous return are matched by reciprocal changes in volume of the left to right shunt. So if the blood flow comes to the right more, it goes to the left. So increase in venous return is matched by the increase in shunt. This is one reason. Another reason is change in pulmonary capacitance. I won't deal with that. Just remember one thing, the pressure equalizes in both the chambers. Okay. Okay, so one important condition is ostium secundum AST. TAPVC is nothing but a large AST. So remember two conditions, ostium secundum AST and TAPVC. The important thing here is, even after surgery, even after Eisenmengerization, AST split remains. Okay, so even after Eisenmengerization, the wide fixed split remains. Why this is important? Because VST Eisenmengerization will cause a single S2. We'll come to that later. I told you one mechanism, right? The P2 closure gets delayed, A2 closure occurs earlier. That mechanism is called as pulmonary hangout interval. Okay, just remember that term, pulmonary hangout interval. I won't tell the details of that, just read it yourself. Pulmonary hangout interval.
That was spoken by
Cardiologists.
yes,
Yes, sir. Okay. So we have discussed two split, wide varying split and fixed wide split.
What is happening?
Single S2.
Single
S2. I'll tell that later again also. Now, before going to paradoxical splitting, I'll tell you something about narrow splitting. Actually, both are the same. What is narrow splitting? P2 comes earlier, A2 comes front. That is narrow splitting. When it becomes more, it comes in the reverse. So the causes of narrow splitting and paradoxical splitting both are the same, nearly the same. So what is the mechanism? Anything which delays A2 or causes early. So இதே ஆர்டரில் சொல்லுங்க. RBBB will cause wide split. LBBB will cause paradoxical split.
Yeah.
LBBB is the most common cause of paradoxical splitting, and this is the one which causes the widest reverse split. So இந்த ஒரு காசு தெரிஞ்சா போதும். One condition which causes early contraction of the right ventricle is RV pacemaker or Wolff-Parkinson-White syndrome type B. Type B na RV க்கு போற accessory path. This one.
No, I
am telling about paradoxical splitting. Wolff-Parkinson-White type B, RV pacemaker, complete LBBB. Conditions which cause late closure of A2 and the severe AS. Severe AS, severe HOCM, left ventricular ischemia, left ventricular infarction. Relatable, right? At least remember one cause which is LBBB or left ventricular failure. I mean left ventricular ischemia.
Type B.
The
severe AS.
Wolff-Parkinson-White type B, RV pacemaker, complete LBB, at least one cause you should remember. Okay. Narrow split is nothing but just one step prior to this one. So the same conditions occur. Severe AS, LBBB occurs, but two important things what they have given is PDA and AR. Narrow split. Okay, PDA and AR. Okay, so till now what we are told, split is there, but it is abnormal. I told you the cause is a wide split. Anything which delays P2, like in RBBB, massive pulmonary embolism, right ventricular infarction, and MR. Wide split. Wide fixed split is ostium secundum ASD and TAPVC. The reason being the changes in pulmonary, changes in venous return is matched by change in the left to right shunt as well as changes in the pulmonary vascular capacitance. Then I told you about narrow split and reverse split. The one important cause being LBBB and severe AS. So in severe AS, it's our exam case. What occurs is narrow split. Now coming to another thing which is called a single S2. If you are hearing only one sound, one S2, it may mean A2 is absent or P2 is absent. So first I'll tell the causes, then I'll tell how both occurs. So absent pulmonary component, one is in older adults. In older individuals, what happens is the chest wall diameter increases. Most of the adults will be having emphysema, smokers emphysema. So emphysema, I told you the pulmonary trunk is close to the left second intercostal space. So anything which increases the distance between the chest wall and the pulmonary trunk, like in obesity, increased chest wall AP diameter, kyphosis, etc., will cause absent pulmonary component.
Okay.
That is the same reason why for a thin individual we can hear P2 very well, right? So absent pulmonary component is actually physiological, maybe physiological. It can occur in older adults. The reason why they are given is in older adults, left ventricular increase in isovolumetric contraction time is there, so pulmonary component is accelerated, they are telling. At least remember emphysema story. Increased AP chest wall diameter, older adults, absent pulmonary component will be there. That is in older. So in older adults, if you are not hearing P2, it is normal. Don't tell that only one component is heard, it is pathological. It is not so. But in pediatric cases, if you are hearing only one heart sound, it should stimulate your brain because there are some conditions which can cause absent A2. There are some conditions which can cause absent P2. So mostly it is due to absent P2. So what are the conditions in pediatrics or congenital heart disease which cause an absent P2 or in other words single S2? Pulmonary atresia and TOF. One of the components of TOF is pulmonary stenosis. There is no flow to the pulmonary valvata, so we will not hear a sound. So pulmonary atresia is one important condition. Next is severe pulmonary valvular stenosis. Remember the case we saw in cardiology, that pulmonary valvular stenosis. Because most of the congenital pulmonary valvular stenosis will be associated with pulmonary valve dysplasia. So we will not hear the sound. So that's the next reason. Dysplastic pulmonary valve. Dysplastic pulmonary valve occurs in Noonan syndrome. Remember this term. Next is TGA. What is TGA? Transposition of great arteries. So normally what I told you, aorta originates from the left, goes to the right, turns posterior and goes below. Pulmonary artery is more of anterior, I told you. In the reverse.
If it is posterior.
Yes. So pulmonary artery goes behind, so I will not hear that sound. Normally, even though aorta is posterior, we will be able to hear the sound because it is loud. So that is the reason why in a normal person, even though aorta is posterior, we will be able to hear the A2 component. But P2 is not like that. It is a low flow chamber, low pressure chamber. So in TGA, if the pulmonary artery goes behind, we will not be able to hear the pulmonary component. So causes of absent P2, one is it is normal or physiological in older age. But in pediatric cases, it could be due to simple, only one answer is pulmonary atresia. Pulmonary atresia, dysplastic pulmonary valve and TGA. Okay, now inaudible aortic component, the same thing. Dysplastic aortic valve, atretic aortic valve. And simple logic, hypotension. Left ventricle is not pumping, so S2 cannot be heard. And decreased myocardial contractility. Hypotension, low systolic pressure, decreased myocardial contractility, atretic aortic valve, calcific or dysplastic aortic valve. Simple. Most of the in congenital cases you are seeing, think of dysplastic aortic valve. Right? Now another possibility can occur in single S2. Both the components can occur together. That is, it is also one of the variant of narrow split. But I told you causes of narrow split will be aortic stenosis and LBBP. But we have two important specific causes for fused. One is Eisenmenger VST. What happens
single
is
S2.
Single S2. Why? Because there's a connection between both the ventricles. So both the ventricles will have the same pressure now. That's why we are having A2 and P2 occur at the same time. Like in VST, Eisenmengerization of VST. It's not a left to right shunt anymore. It's a bidirectional shunt. So both the ventricles will be having equal pressure. So in ASD, Eisenmengerization split is wide because the venous return is matched by changes in the left to right shunt. But ventricle VSD, Eisenmengerization, if it occurs, we will have here a single S2. TOF is another differential diagnosis of cyanotic heart disease in adults. What is my finding there? Absent P2. Again, single S2. So single S2 with cyanosis in adults, think of Eisenmenger VSD or TOF.
Cyanotic single. Okay.
Yes. In PDA, what I told you, narrow split. So congenital heart disease is over. Any adults presenting with cyanotic congenital heart disease, just to see the split. Because we will not be able to hear the murmur once Eisenmengerization occurs. So just to hear S2. If you are hearing S2 as split, it is Eisenmengerized ASD.
VSD.
Single S2, it is Eisenmengerized VSD. Or if you tell that it is due to absent one of the components, then it could be TOF also. How will you differentiate both? Based on the age of one's prior history, etc. If the split is wide, it is Eisenmengerized ASD. If there is a narrow split, it is Eisenmengerized PTA. That's all. Cyanotic heart disease over just by S2. That is why they tell S2 is the key to cardiac auscultation. If you want to know one sound, it is S2. Can both components be absent? S2 கேட்காம இருக்கலாமா? இருக்கும். Again, it is normal in older adults. I already told you in older adults, the P2 is not heard, it is normal. But older adults also have calcification of the aortic valve, right? I told you calcified valve will not produce a sound. So in older adults, there will be calcified aortic valve. So A2 will not be heard. There is increased AP diameter of the chest, so P2 will not be heard. Okay, so till now what I told you normal split, wide fixed split, narrow split, reversed split, single S2 due to absent pulmonary component, single S2 due to absent aortic component and absent S2. Okay, so the first thing which you have to tell in S2 is splitting or not. So just by splitting you can diagnose so many conditions. What's the next thing I told you? S1 S2 heard or not? S2 split I told you. Then you have to mention about the intensity of the S2. Again, very easy. Normally in pulmonary area alone we should be able to hear P2. A2 will be heard in all areas. Okay, in pulmonary area and aortic area, A2 will be louder than P2, A2 will be louder than S1. Am I right? If A2
is
is better heard in the apex.
Mitral area, tricuspid area.
It
then
means A2 is louder.
louder.
Okay, but what are the causes of loud A2 now? Just note down the causes. It is systemic hypertension, aortic root dilatation, transposition of great arteries. Transposition of great arteries, what happens? Aorta comes anterior. So A2 will be loud. Any hyperkinetic states. So all hyperkinetic states will cause a loud S1 and it will cause a loud A2. Very practical application. Any patient with tachycardia, any patient with hyperkinetic state will have a loud S1 and a loud A2. Pulmonary atresia.
Loud A2 because of jet, increase in jet.
Yes. That's the same reason why aortic root dilatation will cause a loud A2. So cause of loud A2 in systemic hypertension, aortic root dilatation, hyperkinetic states, TGA. TGA is due to anterior dislocation. Similarly, pulmonary atresia. Pulmonary atresia, what thing is, we are not able to hear the pulmonary component, so automatically A2 will be loud. It's just a correlation of audible physics. If one sound is not heard, other sound will be loud, right? Pulmonary atresia, it's actually a single S2, but if at all a sound is heard, A2 will be loud. Okay. But loud A2 is not our prime concern. We are more concerned about P2. When do you say P2 is loud? Same thing. I told you P2 is normally heard only in the pulmonary area.
If other areas you will hear P2, then it is loud P2.
Yes. First thing is, if P2 is louder than A2 at the base. So in the aortic area or in the pulmonary area, than the A2, if the P2 is louder, it is loud P2. Next thing is, okay, that's the first 2 points. P2 is louder than A2 at the base. P2 is heard in the right side of the chest, or P2 is heard in the apex, means it is loud P2. Normally splitting should not be heard except in the pulmonary area. If you are able to hear splitting in any area other than the pulmonary area, it means P2 is heard there, right? So splitting is heard anywhere other than the pulmonary area, it means P2 is split. The simplest one is palpable S2. Palpable P2 will be a loud P2.
Palpable
P2. So again I am telling these 4 points. Normally, because this is very important, normally in pulmonary area, A2 is louder than P2. If P2 is louder than P2 at the pulmonary area, it means P2 is loud. If P2 is heard in the aortic area, it is loud. If P2 is heard in the apex, it is loud. If splitting is heard anywhere other than the pulmonary area, it means P2 is loud.
P2 is louder than aortic area.
Remember this word, P2 is louder than A2 in the aortic area.
That is the splitting other than pulmonary area. Same
No.
thing or
There is a minor difference there. I am going to tell that only. So only I am mentioning this point again. P2 is louder than A2 in the base. Splitting heard in areas other than the pulmonary area. Base. Okay. So what I wanted to stress is, even though in the base, if P2 is loud, it will be louder than A2 in the base. Right? I told you, if it is loud, P2 will be heard in the apex. But in the apex, P2 will not be louder than A2. A2 will be louder than P2. Shall I put a diagram now? Here, I will diagram put solitaire. Break up. This is pulmonary area. This is the pulmonary area. Sorry, pulmonary area, I told you, A2, P2. No problem. Okay, if the P2 is louder than A2 in the pulmonary area, it is loud P2. You are clear with this point, right?
Yeah.
Normally, P2 should not be heard in any area other than the pulmonary area.
Yeah.
If it is heard in the apex, that is just hearing of P2 in the apex itself is loud P2.
Loud P2.
But what happens, aortic being a high pressure chamber, in area except in the pulmonary area, A2 will be the loudest component. So if I hear in the aortic area, here A2 will be more than P2.
Yeah.
But P2 will be heard. If I hear in the tricuspid area, both P2 will be heard, but A2 will be louder than P2. Here again, A2 will be louder than P2.
Okay.
Understand? That is why I told you the points again and again. P2 is louder than A2 at the base. It is loud P2. But P2 is heard at the apex, even though it is lesser in intensity than A2. It is loud P2. I am telling this again and again, just to make you answer one question: what is the difference between opening snap and loud P2? Inge sollirava? Opening snap is a diastolic sound. Okay. I told you the events, right? S1 is there, S2 is there. S2 is mainly A2 bar P2. The first diastolic sound will be opening snap. I told you always the problem comes when you hear the third sound. Okay, if you are hearing three sounds in one person, so I S1 in podren, second sound is X1, third sound is Y1. I'm not, S1 I correlated with the pulse, so I know it is S1. But I am able to hear two sounds. The X1 will be obviously S2, any one component of S2, either A2, single S2, whatever it may be, it is some component of S2. Now what is this Y1? It is my question. Whether it is just a delayed P2 or whether it is delayed or whether it is opening snap or whether it is S3, this is my question. Okay, differentiating P2 and OS from S3 is very easy. How? P2 and OS are high pitch sounds, so they are better heard with the diaphragm of the stethoscope, whereas S3 is a low pitch sound, better heard with the bell of the stethoscope. So that simple component will rule out S3. There are some other points to say S3, I'll tell that later. Remember one point. So S3 being a low pitched sound and it's a localized sound, ruling out S3 is very easy. Now the closest differential diagnosis of P2 is what? Opening snap. The diagnosis is different because if you tell opening snap is present, it is just MS. But if you tell P2 is loud, it means he's having MS with pulmonary hypertension. If both are present, it is different. But so our question is whether it is P2 or opening snap. Okay. For that, what you have to know is opening snap is a sound which is better heard between the mitral and tricuspid area. Okay, it is loud sound, better heard everywhere. So in other words, wherever I keep my stethoscope in the chest, opening snap will be heard in the same intensity nearly. So I am hearing a third sound in the apex. My doubt is either it is a P2 or an opening snap. I want to rule out both. So I go above. Or I will have it in other. Okay, I go above. If the sound increases in intensity, what does it mean? Apex it is less than that of A2. When I go above, the third sound becomes louder than the second sound, means it is pulmonary hypertension. If it is in the same intensity, it is going to be opening snap. So to differentiate these 2 points only, I told this point.
Okay.
This is the place where inching method is used. So if you are hearing a third sound somewhere, please inch and go towards the pulmonary area. If a sound from the apex is increasing towards the pulmonary area, the third sound has to be loud P2. Right? இந்த பாயிண்ட்டை புரிஞ்சுக்கிறதுக்கு எனக்கு ஒரு வருஷம் ஆச்சு. So how to identify P2? That's what I told. Move from the second space, either from apex to the second space or from the second space to the apex. So the component which softens will be P2. So if இங்க இருந்து கீழே போனா the one component will soften, that will be P2. If it does not soften, it has to be opening snap. Right. Or another simple technique is there. Take a deep inspiration, P2 should increase. Opening snap is a left-sided sound, so it increases on expiration. Whereas P2 is a right-sided sound, so increases on inspiration. So how to differentiate P2 and opening snap? P2
increases on inspiration.
By inching method, P2 reduces in intensity towards the apex, softens towards the apex, sound increases on inspiration. So P2 புரிஞ்சுதா? So how to say P2 A2? Take an inspiration. During inspiration, the sound which increases will be P2. The sound which decreases will be A2. Assess for the split. How to say loud P2? P2 is louder than A2 at the apex. At the pulmonary area. P2 is heard in other areas other than the apex, even though it is less in intensity than the A2. Palpable P2. Splitting heard in areas other than the cause of loud P2. Thin individuals, it could be physiological, I told you, because pulmonary artery will be closer to the chest. Next is pulmonary hypertension. So one important cause of loud P2 will be pulmonary hypertension. ASD as such can produce loud P2. So the cause of pulmonary loud P2 is very important. One is it could be physiological. Next is pulmonary hypertension. In ASD, what happens? The pulmonary trunk will be dilated because of increased flow through the pulmonary artery. So just the presence of ASD will have a loud P2, even without pulmonary hypertension.
ASD pulmonary trunk will be dilated.
ASD, there is more flow from the left to the right, so more flow to the right ventricle, so more flow to the pulmonary artery. So pulmonary trunk will dilate. In a dilated pulmonary trunk will produce a loud sound, right? So ASD, just due to the dilated pulmonary trunk, even without pulmonary hypertension, we can hear. The same mechanism applies to VSD because there is increased flow through the pulmonary valve. And remember one condition called as straight back syndrome. I told you in kyphosis, the anteroposterior thoracic diameter increases which increases the distance between thoracic wall and the pulmonary artery. So we have soft P2.
Soft.
But in straight back syndrome, the distance between AP diameter reduces. So 5 causes of loud P2 are thin individuals, pulmonary hypertension, ASD, VSD even without pulmonary hypertension, decreased AP diameter. Okay, pulmonary hypertension split. What split occurs in pulmonary hypertension? I didn't mention here. Actually, it is a narrowing of the split. I didn't mention here, only for discussion. Remember, pulmonary hypertension will cause right ventricular hypertrophy, which will cause a narrowing of split. Why? Pressure increases, P2 can contract earlier. But with the occurrence of right ventricular failure, split widens.
Pulmonary hypertension, right ventricular hypertrophy, narrowing of
split. So this point is again very, very important. So if you are seeing a valvular heart disease case, split is narrow, it is just a pulmonary hypertension. But split is wide, it is
Right ventricular
failure.
which you have to worry more, widening of split. It is not the narrowing of split. Okay, something you understood about S2.
Yeah.
This is the toughest one. Okay, just one question. How to differentiate ASD, VSD, PAD, ASN memorization by S2? I have written it in golden.
And VSD, S2 is loud.
Why fixes?
Okay, loud. I am asking about split.
Split.
You are right. P2 will be loud in both VSD and ASD due to increased flow. But how to differentiate VSD and ASD? ASN memorization, because no murmur will be heard during ASN memorization.
There will be wide fixed split.
Right.
In VSD, there will be
Pressure equalization between two chambers. So S2 will be single. A to P2 will fuse. PDA will be narrow split test.
No.
This is very important question. Okay. 5 minutes break.
Yeah.